Usually when we talk about a medical diagnosis, there's this expectation of clinical precision.
Right, like structural engineering or something.
Exactly. I mean, you fracture a radius, the X-ray shows that jagged white line, and the attending physician just points to the screen and says, well, there it is.
Yeah, it's broken. It's entirely binary.
Right. The pathology is localized, it's visible, and the mechanical solution is just straightforward.
And as humans, and especially as clinicians, we crave that kind of visible, perfectly categorized certainty.
But then you step into the world of pediatric toxicology. You step into the chaotic reality of childhood poisoning, and suddenly that X-ray machine is, for the most part, completely useless.
Oh, absolutely. I mean, you are looking at a diagnostic landscape that is entirely hidden.
We're basically operating in the dark. We're relying on secondhand accounts, contradictory symptoms, and this invisible chemical warfare happening at the cellular level.
It is the absolute definition of diagnostic muddy waters.
Yeah.
You are essentially doing forensic pathology on a living, constantly changing subject who, frankly, cannot speak to you.
Which is terrifying, and that is exactly the terrain we're mapping out today for you.
Yeah, it's a massive topic.
It really is. So for this deep dive, we are pulling our clinical framework directly from a really comprehensive presentation on childhood poisoning by Dr. Megbelaine Fadakemi, dated November 2025.
It's an absolute treasure trove of data.
Yeah, moving from high-level epidemiology all the way down to the biochemical mechanisms of specific household toxins.
I love how she starts it.
Yes. Dr. Fadakemi actually opens this massive presentation with a philosophical hook. She pulls two historical quotes that attempt to define what we are even dealing with.
Right, trying to define what a poison actually is.
Exactly. The first is from Paracelsus in the 1500s, who famously stated, "What is there that is not poison? All things are poison, and nothing is without poison."
A classic.
And then building on that, William Withering in 1789 added, "Poisons in small doses are the best medicines, and useful medicines in too large doses are poisonous. Solely, the dose determines that a thing is not a poison."
Those two quotes are pretty much the bedrock of modern toxicology. I mean, the dose makes the poison.
Okay, let's unpack this right out of the gate, though. Because if literally everything is a poison depending on the dose...
Like water or oxygen.
Right. If pure water can be a poison, if ambient oxygen can be a poison, doesn't that make the definition almost too broad to be clinically useful?
I see where you're going with this.
I mean, if I am an ER physician, how do I practically approach a poisoning if the definition includes, the water in the sink?
That is a highly practical pushback. If the word means everything, it means nothing.
Exactly.
Medically, we tighten the definition, right? Poisoning is exposure to a chemical or agent that adversely affects the functioning of an organism.
Okay, but clinically?
Clinically, you don't look at the substance in a vacuum. You don't just look at the dose. Fadeki's framework emphasizes that clinical poisoning is this complex collision of three distinct variables.
Right, the agent, the child, and the family environment.
Exactly. We evaluate riskful environments versus the biological developmental behaviors of children.
So it's never just, did they swallow a chemical?
No, never. The clinical question is, how did this specific child, at this specific neurodevelopmental stage in this specific socioeconomic environment, encounter this specific dose?
Wow. Which brings us directly into the epidemiology of exploration, the who, the how, and the where.
This is where the numbers get really grounding.
Yeah, I want to put you, the listener, in a specific scenario right now. Look around your house. Look under the kitchen sink. Look on the bathroom counter. Look in the garage.
Because that's where it happens.
According to the data in this presentation, that is exactly where the danger is. 90% of childhood poisonings occur at home.
90%. That number completely shatters the illusion that poisoning is some external stranger danger threat lurking in the woods or the streets,
The call is coming from inside the house.
Literally.
And breaking down the pie chart of how these exposures actually happen physically, ingestion is the overwhelming leader at 79%.
Which makes sense for kids.
Right. But it's not the only vector. We have dermal exposure at 6.3%, ophthalmic, so the eyes, at 5.3%, inhalation at 5.1%, bites and stings make up 3.1%, and parenteral, or injected, is just 1%.
But that 79% ingestion rate, that dictates nearly everything about our medical response protocols.
Because it's all going into the stomach.
Exactly. It means the primary battleground is the gastrointestinal tract and the liver's first-pass metabolism.
Looking at the demographics, the peak incidence lands squarely at 2 years old.
Toddlers.
But there is a really interesting bimodal distribution in the data regarding intent.
Right, the difference between unintentional and intentional.
Yeah. Unintentional poisonings skew heavily toward males in that toddler age group. However, intentional poisonings, which the text notes are typically adolescent suicide attempts, skew heavily toward females.
Two entirely different clinical and psychological challenges.
Yeah.
I mean, the toddler doesn't know any better and is acting on pure instinct.
Just exploring.
Exactly.
Right.
Whereas the teenager is in profound psychological distress.
Right.
The medical management might look similar in the ICU, but the psychiatric follow-up and the root cause are just worlds apart.
Fatakimi also breaks down the environmental factors, contrasting industrialized settings with resource-poor settings.
This is a crucial distinction.
In industrialized areas, you see a high prevalence of pharmaceutical overdoses, poisonous plants, bleach, and toilet bowl cleaners.
Right.
But in resource-poor settings, the primary agents shift to things like kerosene used for cooking, caustic soda used for soap making, unrefined alcohol, and scattered agricultural chemicals.
Yeah, it changes the whole landscape of what you're looking for.
There's actually a very striking image in the text showing a chaotic spill of household cleaner, bleach, toilet bowl cleaner, and brightly colored pills scattered across a floor.
If we connect this to the bigger picture, that image is the perfect visual representation of the collision I mentioned earlier.
How so?
Well, if we look at the biological reality of 2-year-old, we have a highly mobile, highly inquisitive human who is biologically programmed to explore their environment.
Right, they have to touch everything.
And what is their primary mechanism for data collection? Hand-to-mouth behavior.
They just put it right in their mouths.
Every time. They don't just look at an object, their instinct is to taste it, to feel its texture with their mouth.
Right, they reach for anything brightly colored, anything that looks like juice, anything that looks like candy.
So when you combine an evolutionary drive to explore with a modern, poorly organized home where, say, caustic chemicals are stored in old water bottles under a sink.
Poisoning is not a freak accident.
No. It is almost a statistical inevitability.
Wow. And the presentation doesn't let parents entirely off the hook when it comes to intent either.
Oh, the medical ignorance factor.
Yeah, it explicitly notes that ignorance plays a massive role. It mentions cases where parents deliberately overdose a child with pharmaceuticals to, quote, speed up recovery,
Which is just heartbreaking.
seemingly unaware of the hepatic or renal limits of the drugs they are administering.
It is a tragic misapplication of logic. I mean, the parent sees the child suffering, gives them the therapeutic dose of acetaminophen, and when the fever doesn't break in 20 minutes...
They just give them another dose?
And another. They operate under the assumption that more medicine equals a more aggressive attack on the illness.
It circles right back to Paracelsus.
Exactly. They forget, or never knew, that the dose makes the poison.
Okay, let's talk about the immediate aftermath of that exposure. A parent walks into the kitchen and sees the toddler holding an empty bottle of drain cleaner or a half-empty bottle of kerosene.
Total panic mode.
Complete panic. The presentation outlines extremely strict rules for home treatment versus hospital resuscitation.
So these are important.
The home care rules are essentially, do not induce vomiting. If a strong acid or alkali is suspected, give milk or water. For skin exposure, flush with copious lukewarm water, do not apply ointments. For eyes, flush with a gentle stream for 10 minutes, no eye drops, and bring the vomitus and the container to the hospital.
Right.
I need to push back on that first rule, though. Do not induce vomiting. Have you ever tried to stop a panicked parent from making their gagging child throw up?
It's nearly impossible. It is their most primal instinct.
The kid swallowed poison, so the logical brain says get the poison out. Telling them to give a sip of water and wait feels like medical negligence to a terrified parent.
I completely understand the psychological torture of that moment for a parent, and it feels utterly counterintuitive.
Right.
But we have to look at the anatomy and physics of the gastrointestinal tract.
Yes.
The stomach lining is built to handle highly acidic, hostile environments.
Because it produces hydrochloric acid anyway.
Exactly. It's tough. The esophagus, however, is a delicate muscular tube.
Oh, I see.
When a child swallows a corrosive chemical, say an alkaline drain cleaner, it burns the esophagus on the way down. If you jam your finger down their throat and induce violent emesis, you are forcing that highly reactive chemical back up the esophagus.
Burning that delicate tissue a second time.
The double burn.
The double burn.
And it gets worse. When a child is violently vomiting, they are gasping for air.
So they inhale it.
The risk of aspirating that corrosive vomit directly into the trachea and the lungs is incredibly high. The lungs cannot handle fluid, let alone a corrosive fluid.
You take a localized gastric problem and instantly turn it into a fatal respiratory failure.
That is why you never ever induce vomiting for corrosives or hydrocarbons.
The instruction to give milk or water is fascinating too. The text specifically notes, don't give palm oil. I assume that is a culturally specific remedy.
Yes, in certain regions, palm oil is a traditional home remedy believed to coat the stomach or neutralize toxins. Medically, introducing heavy oils can complicate later treatments, obscure endoscopic evaluations, and in some cases, actually alter the lipid solubility and absorption rate of the toxin.
Making it absorb faster.
Potentially. The goal with water or milk is simple dilution. You are just trying to lower the concentration of the chemical resting against the gastric mucosa without triggering a vomiting reflex.
I look at these home rules, the copious water, flushing without ointments, not using eye drops, bagging the vomitus, and it sounds exactly like the preservation of a crime scene.
That's a great way to put it.
You aren't trying to solve the case at home. You are trying to freeze the damage, stop the chemical reaction from compounding, and safely transport the biological evidence to the forensics team.
That is the perfect mental framework. You are securing the scene. I mean, if you put an ointment on a chemical skin burn, you might accidentally trap the chemical against the tissue.
Oh, making it worse.
Or worse, the ointment's base might react with the toxin to generate an exothermic reaction.
Creating a thermal burn on top of a chemical burn?
Exactly. Copious water dilutes and removes. That's it.
So the child arrives at the hospital emergency department. The resuscitation protocol kicks in. The text outlines the ABCs. Ensure breathing, stabilize circulation.
Basic life support first.
Right. If the child is in shock, you treat with IV isotonic solutions, specifically normal saline and vasopressors like dopamine to maintain perfusion.
Getting the blood pressure up.
If there are burns from acids, alkalis, or petroleum distillates, you decontaminate with sterile saline, administer anti-tetanus prophylaxis, and alert the burns unit. Treat arrhythmias and seizures standardly.
Standard trauma response.
But Fadikemi emphasizes that while the medical team is stabilizing the vitals, the most critical diagnostic tool isn't a CT scan. It is the history taken from the parents.
Because without the history, we are fighting a ghost.
Right.
We need the exact product name, the active ingredients, the estimated time of ingestion, and the magnitude of the exposure. Was it a sip or was it the whole bottle?
Speaking of magnitude, there is a clinical pearl in this text regarding kerosene that is absolutely terrifying.
The 1 milliliter threshold.
Yes. It states that ingestion of as little as 1 milliliter of kerosene is enough to cause severe symptoms, 1 milliliter. A standard kitchen teaspoon is 5 milliliters. We are talking about a fraction of a teaspoon, a tiny splash.
That single statistic changes the entire temperature of the emergency room.
I bet.
If a parent says, I think they only got a little bit on their lips, that is no longer a comforting statement. 1 milliliter is the threshold for severe, potentially fatal pulmonary pathology.
So you can't just wait and see.
It dictates that we cannot afford a wait-and-see approach for symptoms to develop. We have to assume worst-case scenario immediately.
But what happens when the parents didn't see the ingestion? They just found the toddler seizing on the floor or entirely unresponsive.
The doctor has no history.
Exactly. This is where the presentation transitions into the detective work, reading the body's physiological clues through what we call toxidromes or toxic syndromes.
The fun part of toxicology.
Fadikemi lists 7 primary toxidromes. Let's not just read the list, though. Let's run a clinical simulation. I am going to throw a patient presentation at you, and you break down the toxidrome and the likely culprits.
I love it. Bring them in.
Okay, patient 1. A 3-year-old is wheeled in. They are profoundly delirious, picking at invisible things in the air.
Okay.
Their skin is flushed, incredibly red, and radiating heat, but they aren't sweating at all, completely dry. Their pupils are dilated massively, so mydriasis.
Yeah.
And the nurse notes they haven't produced any urine. They have massive urinary retention.
You are describing the classic anticholinergic toxidrome.
Anticholinergic.
The underlying mechanism here is the blockade of acetylcholine receptors, specifically the muscarinic ones, across the entire parasympathetic nervous system.
And what does acetylcholine normally do?
Acetylcholine is the neurotransmitter that tells your body to rest and digest. It controls your secretions, your bowel movements, your pupillary constriction. When you block it, all those systems just shut down.
So the body basically loses its cooling and fluid release systems.
Exactly. The classic medical school mnemonic is mad as a hatter for the delirium,
Right.
red as a beet for the cutaneous vasodilation. Blind as a bat because the dilated pupils can't accommodate light. Hot as a hair because they can't sweat to dissipate heat. And dry as a bone because all exocrine gland secretion has stopped.
That's a great mnemonic. And what causes this?
The culprits here are usually belladonna alkaloids, Jimson weed, or incredibly common over-the-counter antihistamines like diphenhydramine.
Oh, wow, like Benadryl.
Yep.
Okay, patient 2, the exact opposite. A child is brought in and they are leaking fluid from everywhere. Profuse salivation, tears streaming down their face, severe vomiting, uncontrollable diarrhea.
Messy.
Very. Their pupils are constricted down to pinpoint smiosis, and you can hear them wheezing from severe bronchospasm while their skeletal muscles are visibly twitching under the skin.
This is the cholinergic toxidrome. It is the physiological mirror image of the first patient.
So instead of blocking it,
Instead of blocking acetylcholine, the toxin has caused a massive uncontrolled flood of it. The primary culprits are organophosphate insecticides or certain nerve agents and occasionally black widow spider bites.
what is actually happening at the cellular level to cause that flood?
Well, organophosphates work by inhibiting acetylcholinesterase.
Which is?
That is the enzyme whose sole job is to sweep acetylcholine out of the synaptic cleft after it has fired a signal. Think of a light switch. You flip it on, the light turns on. Acetylcholinesterase is what flips the switch back off.
Okay.
Organophosphates jam the switch in the on position. The nervous system is constantly firing, telling the tear ducts to produce tears, the bowels to empty, the lungs to constrict, and the muscles to contract.
That sounds exhausting.
It is. That is why you see the fasciculations and the muscle twitching eventually leading to paralyzing fatigue.
Wow. All right, patient 3, a teenager. They are exhibiting severe tremors, muscular rigidity, and their neck is painfully twisted to one side, a torticollis. And their eyes are involuntarily rolling completely upward into their head, locked in that position.
That is an extrapyramidal syndrome, specifically an oculogeric crisis.
Oculogeric crisis.
It is incredibly distressing for the patient because they are fully conscious but have lost control of their motor pathways.
What causes that?
This is typically caused by dopamine receptor antagonists. We see this with antipsychotic medications like haloperidol or antiemetics like phenothiazines. The toxin is disrupting the basal ganglia in the brain, which coordinates smooth, voluntary movement.
Got it. Patient 4, a toddler breathing incredibly deep and fast hyperpnea. They are restless, running a high fever, tachycardic, and their blood gas shows a severe metabolic acidosis.
The hypermetabolic syndrome, the most common culprit here is salicylates, which is aspirin.
Aspirin.
Yeah, aspirin poisoning is fascinating and dangerous because it uncouples oxidative phosphorylation in the mitochondria.
Break that down for us. What does uncoupling mean in this context?
Your mitochondria are the power plants of your cells. They burn fuel to create ATP, which is cellular energy. Normally, that process is tightly coupled. Fuel goes in, ATP comes out.
Right.
Aspirin disrupts that machinery. The cell keeps burning fuel at a massive rate, but it can't capture the energy as ATP. Instead, all that energy is released as raw heat.
Oh, that's why the child has a high fever.
Exactly. And because the body is burning through oxygen to fuel this useless process, the respiratory center in the brain screams, "We need more oxygen," triggering the deep, rapid breathing.
And the acidosis.
The byproduct of all this chaotic metabolism is lactic acid and keto acids, driving the severe metabolic acidosis.
Patient 5, found unresponsive. Profound central nervous system depression. They are hypothermic, their blood pressure is tanking, they're barely breathing hypoventilation, and they have bilateral pinpoint pupils.
The classic narcotic toxidrome, opiates or heroin.
Really slowing everything down.
Yeah, the drug is binding to the mu-opioid receptors in the central nervous system, which severely depresses the brainstem's respiratory drive. The pinpoint pupils are a hallmark, although not exclusive sign.
Okay, patient 6, the opposite energy level. Bouncing off the walls, extreme excitation, borderline psychosis, heart rate is through the roof, blood pressure is dangerously high, breathing rapidly, and massive dilated pupils.
Sympathomimetic syndrome. This is a massive surge of catecholamines, epinephrine, norepinephrine, dopamine.
So, stimulants.
You are looking at amphetamines, cocaine, or severe caffeine overdoses.
Yeah.
The central nervous system's fight or flight mechanism has been artificially slammed into overdrive.
So what's the big danger there?
The danger here isn't usually respiratory depression. It's cardiovascular collapse, arrhythmias, or severe seizures.
And the final one, photochemulus, is the withdrawal syndrome. This is the cessation of alcohol, barbiturates, or narcotics.
Right.
The symptoms are abdominal cramps, diarrhea, lacrimation, sweating, goose flesh, yawning, and tachycardia.
This is the body's violent recalibration. I mean, if a nervous system has been constantly depressed by narcotics, it adapts by ramping up its excitatory pathways to maintain equilibrium.
Just to stay functioning.
Right. When you suddenly remove the narcotic, those excitatory pathways are left running completely unchecked, causing the severe agitation and autonomic storm of withdrawal.
So we have mapped out the physical clues, the toxidromes. But if you are dealing with a mixed ingestion or something that mimics a natural illness or you need precise concentrations for an antidote, you have to look at the labs.
The numbers don't lie.
Fadekimi's presentation lays out some strict rules for this phase. Urine is usually the best sample for a broad drug screen, but blood levels are absolutely integral for managing specific poisons. Salicylates, acetaminophen, iron, methanol, and ethylene glycol.
Because you need the exact concentration.
And X-rays are highly utilized to identify radiopaque poisons like arsenic, iron, and lead, or to show evidence of fluid aspiration in the lungs.
The golden rule of the lab phase is knowing what fluid to pull. Urine is your wide net screening tool because the kidneys concentrate the metabolites.
But blood is different.
Blood is your precise magnitude indicator. You can't calculate a specific antidote dose based on a urine screen. You need the serum concentration to know exactly how much of the drug is circulating and threatening the organs.
But the presentation highlights two vital life or death exceptions regarding lab work.
Oh, these are critical.
Fadekimi makes it very clear. Opioid treatment is based on clinical symptoms, not blood levels. And cyanide poisoning treatment must never be delayed by waiting for a drug screen.
Those two exceptions are drilled into every medical student. I mean, if a child comes in with pinpoint pupils and a respiratory rate of 4 breaths a minute, you do not wait 45 minutes for a toxicology panel to confirm they took oxycodone.
You just act.
You administer naloxone immediately. You treat the respiratory depression, not the lab value.
And
Cyanide is even more critical. Cyanide binds to cytochrome C oxidase in the electron transport chain. It completely paralyzes the cell's ability to use oxygen.
So they're suffocating on a cellular level.
Exactly. The blood is full of oxygen, but the cells are suffocating. It is intracellular asphyxiation, and it happens in minutes. If you wait for a lab confirmation for cyanide, you will be confirming the diagnosis on a corpse. You must treat the clinical presentation aggressively and immediately.
Let's transition right into those treatments then. Section 4 details decontamination, antidotes, and elimination. First, the presentation gives us the rapid-fire antidote roster. Let's talk about how these actually function as chemical antagonists.
Okay.
For acetaminophen, the antidote is N-acetylcysteine. For iron, it's desferoxamine. For anticholinergics, physostigmine. For benzodiazepines, flumazenil. For digitalis, digoxin-specific Fab fragments. And for opioids, naloxone.
That's the core list.
How does something like naloxone actually reverse a dying child's respiratory failure in seconds?
Well, naloxone is a competitive antagonist. It has an incredibly high affinity for the mu-opioid receptors in the brain, much higher than the opioid itself.
So it beats the drug to the receptor.
When you inject it, it physically rushes into the brain, kicks the opioid molecules off the receptors, and binds to them itself. But crucially, naloxone doesn't activate the receptor. It just blocks the keyhole.
Wow.
The brainstem instantly recognizes that the depressant signal is gone, and the respiratory drive kicks back in. It is one of the most miraculous things you could witness in an emergency room.
And what about something like desferoxamine for iron?
That is a cheerleader. Chile comes from the Greek word for claw.
A claw.
Yeah, desferoxamine molecules essentially act like chemical claws. They find the free toxic iron floating in the bloodstream, grab onto it, wrap around it to neutralize its reactivity, and form a water-soluble complex that the kidneys can safely pee out.
But Fadekimi's text points out that we do not have magic bullet antidotes for everything. In fact, for most household chemicals, there is no antidote. The primary strategy becomes GI decontamination, physically getting the poison out of the gastrointestinal tract before it crosses into the blood.
Getting it out is the main goal.
The presentation details 3 historical methods. The first is emesis, inducing vomiting using syrup of ipecac. It is dose-dependent by age, usually 10 to 30 milliliters, and you can repeat it once in 20 minutes if necessary.
Right.
However, the text explicitly notes the American Academy of Pediatrics recommends it for use only in the hospital or at home, strictly on the advice of a health professional.
Yeah, ipecac has largely fallen out of favor in modern toxicology.
Really? Why is that?
It works by irritating the gastric mucosa and stimulating the chemoreceptor trigger zone in the brainstem. But the problem is, it takes 20 to 30 minutes to work. In toxicology, 30 minutes is an eternity.
Oh, so the body's already absorbing it.
Exactly. By the time they vomit, a huge portion of the drug is already in the small intestine being absorbed. Plus, prolonged vomiting prevents us from administering other, more effective oral treatments.
The second method is gastric lavage, literally pumping the stomach. The protocol states it requires endotracheal intubation first to protect the airway, and it is generally not recommended for young children because it has remarkably poor efficacy. It removes only about 30% of the ingested poison.
Lavage sounds great in theory. Put a tube down, wash it out. But to get a tube big enough to suck up intact pills, you have to use a massive orogastric hose.
That sounds awful for a kid.
It is highly traumatic for a small child. And the fluid you pump in can sometimes accidentally push the poison further down into the duodenum, speeding up absorption. And as the text notes, it leaves 70% of the poison behind. The risk-to-benefit ratio is very poor, unless a patient presents within minutes of a massive life-threatening ingestion.
Which leaves the third and most efficacious method, activated charcoal. The dose is 1 to 2 grams per kilogram, maximum 100 grams. You repeat it until charcoal is passed in the rectum.
The messy one.
But Fideikemi notes the taste and texture are highly unpalatable, meaning you often have to administer it via a nasogastric tube if the patient is vomiting.
It's like drinking black mud.
How does charcoal actually trap the poison? Fideikemi uses the word adsorbs with a D.
Adsorption is a surface phenomenon. Activated charcoal is treated with high heat and gas to expand its internal surface area. If you look at it under an electron microscope, it looks like a microscopic cavern system.
Taverns.
Yeah, a single gram of activated charcoal has the surface area of a tennis court. As it travels through the gut, heavy, complex drug molecules wander into these microscopic caverns and get trapped there by weak intermolecular forces called van der Waals forces.
That's incredible.
The charcoal holds onto the poison and the whole complex is safely defecated out.
But the text gives us a very specific list of things charcoal is completely useless for. Acids, alkalis, ethanol, methanol, ethylene glycol, iron, and lithium. If it's a microscopic sponge, why doesn't it trap those?
Because of molecular physics. Activated charcoal is great at trapping large, complex organic molecules. But things like lithium or iron are tiny, highly ionized molecules. They are too small and carry too much charge to get caught in the carbon lattice.
So they just pass right through.
Right. Alcohols like ethanol and simple corrosives like acids just slip right past the van der Waals forces. Giving a child a cup of black charcoal slurry for an iron overdose won't absorb the iron, but it will make it impossible for the gastroenterologist to see the burns in the stomach during an endoscopy because everything is coated in black sludge.
Oh, that's a massive red flag. So there are very strict rules about when to use decontamination. But Fideikemi provides a critical mental framework for when you must absolutely never induce emesis or perform lavage. You hinted at this earlier.
Yes, the absolute contraindications. I teach this as the 3 C's.
The 3 C's.
You never induce vomiting if the patient is in a coma, having a convulsion, or if they swallowed a corrosive.
Okay, coma, convulsion, corrosive.
If they're comatose or convulsing, their gag reflex is compromised.
Right.
If they vomit, they will aspirate gastric acid into their lungs and die of chemical pneumonitis. If it's a corrosive, you trigger the double burn we discussed.
The presentation adds a fourth vital contraindication. Petroleum distillates in children under 6 months, again, due to the catastrophic risk of inhalational chemical pneumonia.
Exactly.
So if we can't get it out of the stomach and it crosses into the blood, how do we get it out of the body faster? The text outlines 2 methods for enhancing excretion.
Right, pushing it out through the kidneys.
The first is alkalinization of the urine. You use an IV sodium bicarbonate solution to manipulate the urine pH, holding it between 7.5 and 8.5. This is used specifically to trap weak acids like salicylates and phenobarbital.
This is one of the most elegant physiological tricks in medicine, relying on the Henderson-Hasselbalch equation. It's called ion trapping.
Ion trapping.
Normally, as blood filters through the kidneys, lipid-soluble drugs easily slide through the tubule membranes and are reabsorbed back into the bloodstream. But if a molecule carries an electrical charge, if it is ionized, it becomes water-soluble and cannot cross the lipid membrane. It gets trapped in the urine fluid.
So how does the bicarbonate help?
By infusing sodium bicarbonate, we make the urine basic. When a weak acid like aspirin hits that basic urine, it drops a hydrogen ion and becomes electrically charged. Boom!
It's trapped.
It is trapped in the renal tubule and gets flushed down into the bladder. We are literally altering the local chemistry of the kidneys to accelerate excretion without needing any invasive machines.
But for certain highly toxic substances where ion trapping doesn't work, Fadikemi notes the use of hemodialysis, physically filtering the blood with a machine.
Right.
The text lists indications for dialysis. Poisons with low viscosity and low protein binding, like ethanol, ethylene glycol, lithium, methanol, and severe salicylate toxicity.
Dialysis is the heavy artillery. You are bypassing the kidneys entirely and running the child's blood through an external filter.
Which is a big deal for a toddler.
It is highly invasive, requires a central line, and carries significant risks of hemodynamic instability in a small child. You only pull out the dialysis machine when the toxin is lethal, the blood levels are astronomical, and the molecule is small enough to actually pass through the dialysis membrane.
If we pivot from general treatments to the actual clinical behavior of these toxins, Section 5 of Fadikemi's presentation provides deep dives into specific high-risk agents. Let's start with kerosene.
A huge problem globally.
This is incredibly common in resource-poor settings where it is utilized daily for cooking and lighting, often improperly stored in soda bottles or cups.
Very easy for a kid to grab.
The presentation notes that kerosene actually has a terrible taste, so usually only a small amount is ingested by a child before they stop. It is poorly absorbed in the GI tract, however, it possesses very specific physical properties. It is highly volatile, has low viscosity, and low surface tension.
Those properties are the real killer.
The clinical symptoms appear rapidly within 30 minutes to 6 hours. A persistent cough, grunting, cyanosis, which is a blue discoloration of the skin, and profound CNS depression due to hypoxia. Radiographic abnormalities like periclar opacities and basilar infiltrates show up on a chest X-ray within 6 hours. Here's my question. We established it is swallowed into the stomach, and the text says it is poorly absorbed by the gut. So why does a gastrointestinal ingestion cause massive respiratory failure, cyanosis, and opacities in the lungs?
It entirely comes down to those three physical properties you listed: volatility, low viscosity, and low surface tension.
The viscosity especially.
Viscosity is resistance to flow. Honey has high viscosity, it's thick and slow. Kerosene has incredibly low viscosity. It is thinner than water. It is slippery. It literally crawls. When a toddler takes a sip of kerosene, it doesn't just swallow neatly down the esophagus. Because it is so thin and has such low surface tension, it spreads instantly. It easily bypasses the epiglottis, the flap that protects the airway, and slides right down the trachea. The damage is almost entirely due to aspiration.
It just physically outmaneuvers the body's mechanical defenses.
Yes, and once it gets deep down into the lower respiratory tract, into the tiny air sacs called alveoli, it unleashes its chemical damage. The text notes specifically that kerosene inactivates type 2 pneumocytes.
What do those cells do?
Type 2 pneumocytes are the specialized factories in your lungs that manufacture pulmonary surfactant.
Surfactant?
Think about blowing up a wet balloon. If the inside of the balloon is wet, the sides stick together, and it takes immense pressure to blow it up. Surfactant is a soapy, lipid-rich substance that coats the inside of your alveoli, lowering the surface tension so the air sacs don't collapse and stick flat every time you exhale. This is governed by Laplace's law.
Oh, I see.
Kerosene acts as a lipid solvent. It literally dissolves the surfactant layer and destroys the pneumocytes that make it. Without surfactant, the tiny air sacs snap shut and collapse.
Oh, they literally can't breathe.
The child is trying to breathe, but no oxygen is crossing into the blood. That is why you see the grunting, the cyanosis, and the secondary CNS depression. Their brain is suffocating because their lungs have structurally collapsed. And again, this is exactly why if a child swallows kerosene, you never induce vomiting. You guarantee massive aspiration.
That is a brilliant and terrifying explanation. The physical fluid dynamics dictate the lethality.
Exactly.
Let's look at another structural destroyer mentioned in the text: caustic soda. Fadikemi points out its wide availability in homes for making soap and dyeing clothes. It is a clear liquid. It looks exactly like water. When ingested, it burns the mouth, the throat, and the esophagus, leading to severe strictures.
Very dangerous stuff.
The presentation highlights a vital distinction in chemical burns that we must understand. It states that acids cause coagulative necrosis, whereas alkalis like caustic soda cause liquefactive necrosis. Walk us through the chemistry of that difference.
It is a difference between a frying egg and a melting bar of soap.
Okay, explain that.
When a strong acid hits organic tissue, it denatures the structural proteins. It essentially cooks them the way heat turns a clear, raw egg white into a solid, opaque mass. It's a coagulative necrosis.
So it hardens.
It creates a tough, leathery scab known as an eschar. While the burn is horrific, that solid eschar actually acts as a physical barrier. It limits the penetration of the acid, stopping it from burning deeper into the underlying muscle. It is somewhat self-limiting.
But alkalis are different.
Alkalis behave entirely differently. Caustic soda causes liquefactive necrosis through a process called saponification. It reacts with the fats in your cell membranes and literally turns your tissue into a soapy liquid.
Just melting it.
There is no scab formation. There is no barrier. The chemical just keeps melting deeper and deeper, dissolving layer after layer of the esophagus. It can burn right through the esophageal wall and leak into the mediastinum, the cavity containing the heart.
Which is almost universally fatal.
Absolutely. And even if the child survives the acute liquefactive burn, the long-term nightmare is just beginning. As that massive, deep circumferential burn attempts to heal, it lays down dense, rigid scar tissue.
The strictures.
Over weeks and months, that scar tissue contracts, narrowing the esophagus until it is completely pinched shut. These are called strictures. The child literally loses the physical ability to swallow solid food. They require repeated, painful surgical dilations of the esophagus for years, sometimes for the rest of their lives, just to be able to eat.
Moving to Section 6, Fideikommi covers what I think of as the hidden hepatotoxins. These are the liver and cellular killers that disguise themselves as the most benign, trusted items in our medicine cabinets.
Oh, this section is crucial.
The most prominent is acetaminophen or paracetamol. The text rightly calls it the most widely used analgesic and fever reducer in the world. It has an exceptional safety profile at the therapeutic dose, which is capped at 75 milligrams per kilograms per day for children.
Right. Very safe normally.
But the acute toxic dose is anything greater than 200 milligrams per kilogram in children, or a flat 7.5 to 10 grams in adolescents.
Which isn't as much as people think.
The clinical presentation of an acetaminophen overdose is deceptive, divided into 4 distinct stages.
Let's break those down.
Stage 1 occurs from 30 minutes to 24 hours. The symptoms are entirely nonspecific: anorexia, nausea, vomiting, pallor, and diaphoresis, which is sweating.
Basically, they just look like they have a standard stomach bug.
Right. Then stage 2 is from 18 to 72 hours. The patient develops right upper quadrant abdominal pain, tenderness, and oliguria, a decrease in urine output.
Because the liver is starting to swell.
Stage 3 hits at 72 to 96 hours. This is the peak hepatic phase. Profound jaundice, hypoglycemia, coagulopathy, inability to clot blood, hepatic encephalopathy, and acute renal failure.
Full systemic meltdown.
And stage 4 is from 4 days to 3 weeks, which is either complete resolution of symptoms or death from multi-organ failure.
Yeah.
To understand why it takes 3 full days for the liver to melt down, Fideikommi maps out the precise pathophysiology. At therapeutic doses, acetaminophen is metabolized in the liver to safe sulfate and glucuronide conjugates, which are excreted in the urine.
The normal pathway.
However, about 2% is metabolized by the hepatic cytochrome P450 system, specifically the CYP2E1 enzyme, to form a highly reactive, incredibly toxic intermediate metabolite called NAPQI.
NAPQI is the villain here.
Normally, the liver has stores of glutathione, which binds to NAPQI and detoxifies it. But in a massive overdose, the primary metabolic pathways are saturated. All the drug is shunted to the P450 pathway, producing a mountain of NAPQI.
Way too much to handle.
The hepatic glutathione stores are rapidly depleted. Once glutathione drops below 30% of normal, NAPQI is left unchecked. It binds covalently to the lipid bilayer of the hepatocytes, causing massive centrilobular necrosis.
You can visualize this brilliantly with a factory analogy. The liver is the body's primary chemical processing plant.
Okay, a factory.
Normally, it takes the raw material acetaminophen and packages it safely into boxes to be shipped out via the kidneys. But there is one small, old machine in the back of the factory, the cytochrome P450 machine. This machine occasionally takes some raw material and accidentally produces a highly volatile radioactive byproduct, NAPQI.
A radioactive byproduct.
Under normal circumstances, the factory has a dedicated hazmat cleanup crew, which is the glutathione. The cleanup crew easily sweeps up the small amounts of toxic waste as it's produced.
That makes sense.
But in an overdose, the main packaging lines break down. The management routes thousands of pounds of raw acetaminophen to that old P450 machine. Suddenly, the factory is pumping out mountains of radioactive NAPQI. The hazmat crew works overtime, but eventually they completely run out of supplies. The glutathione is gone.
And without the cleanup crew.
With the cleanup crew neutralized, the toxic waste spills over, melting the machinery, dissolving the walls, and destroying the entire factory from the inside out.
That perfectly explains the antidote, N-acetylcysteine. You aren't giving a chemical to fight the NAPQI directly. You are sending an emergency supply drop of raw materials to the hazmat crew so they can synthesize more glutathione and resume the cleanup.
Exactly. You're restocking the crew.
But while we are on the topic of deceptive timelines, Fadakemi drops a crucial clinical pearl regarding the 4 stages of this poisoning. The text states, clinical recovery precedes histological recovery.
This is the trap that catches inexperienced clinicians.
That's so.
Look at stage 1 and stage 2. The child comes in vomiting. They feel terrible. You admit them. By day 2, the vomiting stops. They ask for food. The right upper quadrant pain might even subside. To a parent, and even to a nurse, the child looks like they're getting better.
They seem fine.
But microscopically, histologically, the liver is actively dying. The NAKQI is shredding the hepatocytes. The necrosis is spreading silently. If you trust the clinical presentation, if you discharge that child because they, quote-unquote, look better, they will return on day 4 in stage 3.
The peak hepatic phase.
Bright yellow with jaundice, bleeding from their gums because the liver stopped making clotting factors, and comatose from ammonia buildup in the brain. You can never trust how an acetaminophen patient feels. You must rigorously plot their serum blood levels on the Rumack-Matthew nomogram to determine if they need the IV antidote.
The second hidden toxin Fadakemi highlights is iron. It is found in every prenatal vitamin and daily supplement, often coated in bright, sweet, candy-like shells.
Extremely tempting for a toddler.
The presentation notes the severity depends on the exact formulation's elemental iron content. Ferrous sulfate contains 20% elemental iron, gluconate has 12%, and fumarate has 33%. The toxic dose is any ingestion greater than 60 milligrams per kilogram of elemental iron.
And iron toxicity is a dual threat.
Yes, it strikes in 2 distinct ways. First, it exerts a direct corrosive effect on the gastrointestinal mucosa. This leads to severe ulceration, hematemesis, and melena dark, tarry stools from digested blood occurring within 30 minutes to 6 hours.
That's the first hit.
Second, it has a profound systemic cellular effect. Once absorbed, free iron accumulates in the mitochondria of the tissues, causing massive venodilatation, severe hypotension, lactic acidosis, and hepatic necrosis. A serum iron level greater than 500 mg/dL implies severe toxicity.
Iron is an absolute sledgehammer. First, it physically burns the gut lining exactly like a corrosive acid, which is why the child is vomiting blood. But the cellular toxicity is where the real physiological damage occurs. Free iron in the blood acts as an aggressive electron donor and acceptor. It generates massive amounts of reactive oxygen species, free radicals, through what's known as the Haber-Weiss reaction.
So it's basically rusting the cells.
In a way, yeah. These free radicals tear through the cell membranes and assault the mitochondria. The mitochondria completely collapse, cellular respiration halts, and the cells switch to anaerobic metabolism, which floods the blood with lactic acid.
Causing the acidosis.
The blood vessels lose all their tone and dilate massively, crashing the blood pressure. It is a state of profound systemic shock.
And just like acetaminophen, iron poisoning has a deceptive false dawn. Fadakemi's text notes that the GI symptoms often subside over 6 to 12 hours. It looks like the child is stabilizing.
A quiet before the storm.
But then it adds a devastating final note. Gastric scarring and pyloric stenosis may develop 2 to 4 weeks later.
It is the exact same deception. The child stops vomiting blood. The parents breathe a sigh of relief. The worst is over. But that silent phase is just the iron migrating out of the blood and into the cellular organs to initiate the mitochondrial collapse.
Wow.
And if the child survives the acute shock phase, they face the mechanical consequence of the initial burn. As the severe chemical ulcers in the stomach heal, they form thick scar tissue. Specifically, they scar the pylorus, which is the muscular valve at the bottom of the stomach that empties food into the intestines.
And that tightens up.
Over a month, that scar tissue tightens like a noose, creating a pyloric stenosis. The exit to the stomach completely closes off. The child suddenly begins projectile vomiting every time they eat because the food physically cannot leave the stomach. It requires surgical intervention to fix.
Let's move into section 7, which focuses on environmental hazards: alcohol, organophosphates, and lead.
These are the everyday dangers.
The presentation covers alcohol poisoning, noting that ethanol is commonly found in household items like gin, brandy, perfumes, and colognes. It notes a tragic reality of childhood poisoning. It frequently occurs when children just help themselves to gulps of these substances left unattended on low tables or dressers.
Just a toddler taking a sip of perfume.
The lethal dose in children is shockingly low. Fadakemi points out it takes only about 3 milligrams per kilogram to be lethal in a child, compared to 5 to 8 milligrams per kilogram in adults.
Huge difference.
Clinical intoxication appears at a blood concentration of just 50 mg/dL. The signs include gross incoordination, slurred speech, drowsiness, and apneic episodes, periods where the brain completely forgets to breathe.
The respiratory depression is the immediate threat. driven by the ethanol enhancing the inhibitory effects of GABA in the brain. But the presentation highlights a uniquely pediatric, uniquely metabolic vulnerability that makes alcohol so deadly to a toddler.
Hypoglycemia.
Yes.
The specific management slide explicitly dictates that hypoglycemia must be corrected with a 10% dextrose water 5V infusion.
This is a critical physiological difference between adults and children. A child's liver is relatively small, and its glycogen stores, its reserve banks of sugar, are extremely limited.
They just don't have the backup energy.
When a child ingests a large amount of alcohol, the liver stops everything else it is doing to metabolize the ethanol. Specifically, the processing of alcohol alters the NAD to NADH ratio in the liver, which violently shuts down gluconeogenesis, the liver's ability to manufacture new glucose.
Oh, okay.
Because the toddler's glycogen reserves are small, they burn through them in hours. And because the alcohol has shut down the factory that makes new glucose, the blood sugar crashes to zero.
Which is terrifying.
The child doesn't just pass out from being drunk, their brain runs completely out of fuel, leading to intractable seizures, irreversible brain damage, and death. Correcting that blood sugar with IV dextrose is just as critical as putting a breathing tube in to support their respiration.
Let's touch on organophosphates again, which we discussed during the toxidrome section. Fedekemi notes these are common components of agricultural insecticides and residential pesticides.
Right, the cholinergic toxidrome.
We established they inhibit acetylcholinesterase, leading to profound muscarinic and nicotinic effects. The symptoms hit within 12 hours. Excessive salivation, tearing, sweating, blurred vision, muscular twitching, and convulsions.
Nasty stuff.
But for a definitive diagnosis, the text states you need a serum RBC cholinesterase level less than 25% of normal.
That lab value confirms exactly how jammed the neurological switches are. The treatments highlighted by fedekemi atropine and preladoxime are a two-pronged attack.
How they work together?
Atropine works by aggressively blocking the muscarinic receptors. It doesn't fix the enzyme, but it shields the end organs from the massive flood of acetylcholine, stopping the fluid leaking and the bronchospasms. Preladoxin, on the other hand, is the ultimate fix.
It actually unjams the switch?
Exactly. It binds to the organophosphate molecule and literally pries it off the acetylcholinesterase enzyme, freeing the enzyme to go back to work, clearing the synaptic cleft.
The final specific toxin in Fedekemi's presentation is lead, and the tone of the text shifts here. It notes that human exposure to lead remains one of the most widespread and serious environmental health problems, particularly for children. The peak age of vulnerability is under 2 years old, heavily correlated with areas of poor living conditions.
This is the invisible threat.
The routes of exposure listed are incredibly extensive and insidious. It isn't just one bad bottle under a sink. It lists deteriorated lead paint chips, dust on toys, nipple shields, contaminated food wrappings, and cooking utensils.
It's everywhere.
It highlights occupational exposure, noting children are poisoned when parents bring lead dust home on their clothes from working in battery plants, plumbing, or welding. It even lists lead contamination in traditional homemade remedies like ground paprika and cultural eye cosmetics like kohl, tiro, and notenjel.
This is the pivot from acute toxicological emergencies, the dramatic ER resuscitation, to chronic, insidious, invisible poisoning. The child isn't drinking a bottle of drain cleaner. They are absorbing microdoses every single day from the invisible dust on their favorite toy or from the culturally mandated cosmetic applied to their face by a loving parent.
Fedekemi's pathophysiology of lead poisoning is incredibly thorough, tracking its destruction across multiple organ systems.
It really is systemic.
In the bones, it explains that lead deposits heavily in areas rapidly undergoing growth. Specifically in the trabeculae of the metaphysis, the growing ends of the distal femur, fibia, and radii.
It hides in the skeleton.
In the blood, lead has a remarkably high avidity for the sulfhydryl groups of proteins. It binds to essential enzymes in the heme synthesis pathway, severely impairing their function, which inevitably causes a profound microcytic anemia,
making them very pale and weak.
In the kidneys, it aggressively destroys the proximal tubules, causing Fanconi syndrome, lead nephropathy, and eventually chronic tubular interstitial nephritis.
The kidney destruction is severe. But if we connect this structural damage back to the true tragedy of lead, we have to look at the central nervous system.
The text describes the neurological impact with a very specific, devastating sentence. In the developing brain, lead interferes with the selective pruning of synaptic connections, disrupting brain plasticity, neurodevelopmental growth, and cognitive functions.
This is a profound and terrifying concept. A toddler's brain is not just a miniaturized adult brain. It is a hyper-connected, rapidly evolving network of billions of neurons. Actively prunes away redundant or useless synaptic connections to make the primary useful pathways faster and stronger. It is how intelligence and coordination are physically built.
And what does lead do to that?
Lead is a molecular imposter. Its ionic size and charge allow it to mimic calcium perfectly. Normally, calcium triggers the release of neurotransmitters. Lead sneaks into the neurons through the calcium channels and begins firing randomly. It tricks the neurons into releasing neurotransmitters at rest, creating a constant state of chaotic static electricity in the brain.
Oh, wow. So it just scrambles the signals.
This constant, inappropriate firing completely disrupts the delicate pruning process. The brain wires itself incorrectly. It keeps useless pathways and prunes vital ones. The resulting damage, severe language delay, profound learning difficulties, disrupted developmental milestones, aggressive behavioral changes, and hyperactivity is structurally permanent.
Permanent.
You cannot unring that bell. You cannot rewire the foundation of the house once it's built.
The clinical manifestations listed by Fedachemi align exactly with that. Severe irritability, sleeplessness, hyperactivity, language delay, alongside the physical symptoms like recurrent vomiting, chronic constipation, and unusual paleness from the anemia.
But here's the catch.
The text states a shocking diagnostic reality. Approximately 99% of lead-poisoned children are identified by routine blood screening procedures rather than by clinical recognition of lead-related symptoms.
99%. Think about what that statistic actually means. By the time a pediatrician or a parent actually notices the physical symptoms of lead poisoning the vomiting, the severe behavioral changes, the neurological damage has been accumulating for years.
The damage is already done.
The IQ points are already gone. The only way to intercept this tragedy is to proactively screen the blood lead levels of all children living in high-risk environments at ages 1 and 2.
The primary medical treatment mentioned is chelation therapy with drugs like demarcaprol or Suxamer. These drugs bind to the heavy metals in the blood so they can be excreted by the kidneys.
Which is helpful for the acute levels, yeah.
Chelation can halt the ongoing toxicity, and it can save a child from acute lead encephalopathy, but it cannot undo the neurological rewiring that has already occurred in the gray matter.
No, it can't. It just stops further damage.
Which brings us perfectly to the final section of Dr. Fedachemi's presentation: prevention and the true antidote. The prevention guidelines provided are highly practical, focusing entirely on parental behavior and environmental control.
This is where we can actually make a difference.
The directives are clear. Keep all potential poisons out of sight and completely out of reach. If you have a crawling infant or a toddler, household products must be stored above floor level, not in the traditional spot beneath the kitchen sink.
Right.
Use child-resistant closures in the firmly locked mode immediately after every single use. Never, ever transfer a chemical substance from its original packaging into an alternate container, like a soda bottle. Safely dispose of expired or unused medications. Keep household cleaning supplies, medicines, garage products, and insecticides locked in cabinets. And never store food and cleaning products in the same space.
These directives sound like basic, foundational common sense. But when we recall the epidemiological data we opened with, that 90% of all poisonings happen in the home, it proves empirically that these basic steps are constantly routinely overlooked. We normalize the danger of the chemicals we use every day.
Fedachemi also offers some very specific behavioral and psychological advice for parents regarding medications. It commands, do not refer to medicines as candy, and avoid taking medicine in your child's presence. Children love to imitate.
That directly links back to the developmental epidemiology we discussed. A 2-year-old learns primarily by observation and imitation. If they see their parent taking a bright pink pill every morning, their developing brain registers that as a normal, perhaps desirable adult behavior.
They want to do what you do.
They want to take the bright pink pill too. And if a parent tells a sick, resistant child that a chewable ibuprofen is just candy to get them to swallow it, they've just trained the child to seek out that bottle when they want a treat.
You're just setting a trap.
The ultimate medical management for pediatric toxicology isn't a complex, exotic 5E antidote in the emergency room. It's proactive, educated caregivers. It is proper, secure storage. It is rigorous community education. Unintentional childhood poisoning is, as the text starkly concludes, largely preventable.
The final slide of the presentation summarizes exactly that. A reduction in the incidence of childhood poisoning can be achieved if caregivers and parents adopt a proactive stance by storing drugs and household products safely in appropriate places. The key, however, lies in proper awareness and education of the community.
We started this deep dive talking about the murky, hidden nature of toxicology compared to the clean, binary certainty of a bone fracture. Exploring this presentation raises a final, vital question to leave you with.
Oh, absolutely.
If we look deeply at how heavy metals like lead can invisibly alter the fundamental synaptic pruning of a child's brain, permanently disrupting their cognitive growth, their impulse control, and their ability to learn long before any physical symptoms manifest, it forces us to look at the world of a much darker lens.
A completely different perspective.
We have to wonder, how many behavioral issues, how many instances of severe ADHD, how many cognitive challenges in our broader society are actually just the long-term echoes of unrecognized low-level environmental toxicities? How many learning difficulties were born not from bad genetics, but from the invisible paint dust on a windowsill in a child's bedroom?
It fundamentally changes how you look at the physical world around you. To Paracelsus in the 1500s, all things are poison. To William Withering in the 1700s, the dose determines the poison. But in the modern world of pediatric toxicology, the environment and the neurodevelopmental drive of the child determine the exposure.
Beautifully said.
Thank you for joining us on this exhaustive, line-by-line deep dive into the clinical realities of childhood poisoning. We invite you to walk into your kitchen right now and look at the household items under your own sink with a newly educated, highly skeptical eye. Stay curious, stay vigilant, and we will see you next time.